Hello, my name is Kem and I'm one of the TNO SHOs here at Torbay, and today I'm going to be going through compartment syndrome. So just a brief outline of my talk. I'll talk about the history of how it all came into play, the etiology and incidence, the pathophysiology and clinical manifestations, including symptoms, diagnosis and management. So it was first described by gentleman Folkman in 1881. He described that myonecrosis and contracture occurred in some of the patients he had placed in forearm splints. He wasn't quite sure why, but he hypothesized that the splints had led to diminished arterial inflow, which in turn had caused muscle death. Now, his findings were refuted by some other scientists and doctors back then, but in the World War II, there was a significant number of patients or casualties who had suffered crush injuries. What was found was that these patients were brought into hospital. Initially, they were stable, but after a couple of days, they would undergo multi-organ systemic failure, and it was felt that the crush injury had in fact contributed to this. Brunel and Docker then described the first hand compartment syndrome in 1940, and since then research has led us to the following definition of compartment syndrome. It is a pathological condition characterized by elevated interstitial pressure within a closed osteofascial compartment. This then results in microvascular compromise. It is a surgical emergency. Without proper treatment, it can lead to ischemia and eventually necrosis. So if you suspect anyone undergoing compartment syndrome, then immediate management needs to take place. So when I think about compartment syndrome, I've got to imagine a compartment which contains muscles, blood vessels and lymph nodes. It's enclosed within this fascia, which is a thin and elastic sheet of connective tissue that surrounds the muscle compartments, and this limits the capacity for rapid expansion. So anything that reduces size within the compartment or increases content within the compartment can technically lead to compartment syndrome. So things that reduce the size within a compartment include tight dressing such as a cast, tight fascial closures after surgery, or external pressures such as crush injuries as alluded to earlier. Things that can increase the content within the compartment include bleeding or ischemia through trauma or for arterial insufficiency, extravasation. So for example, if a patient is having or supposed to have fluids intravenously but it then goes intramuscularly, that can cause an increase of pressure within the compartment. Thermal injury, venous obstruction, intense athletic activity and penetrating trauma, and poor positioning during surgery. This can all cause or be causes of increased content within the compartment and lead to compartment syndrome. So it's more commonly seen in males, and the majority is seen in trauma. Tibial shaft fractures are actually the most common cause of acute compartment syndrome, and it's associated with a 1 to 10% incidence of the actual disease. So those at most risk of compartment syndrome include males who are younger than 35, and this may be due to them having a larger relative intracompartmental muscle mass or an increased likelihood of being involved in high energy trauma. Also, people with hematological conditions such as haemophilia are at greater risk simply because they can bleed into a closed osteofascial space. So we'll move on to pathophysiology here, and if there's one thing I want you to take from this slide is that it self-perpetuates. Once it begins and it becomes worse and it goes into a vicious cycle, and without any intervention, things get worse and worse and worse. There's two common routes into this. So if there is arterial damage, this will lead to ischemia and then to edema, direct injury which leads to edema, and then into increased compartmental pressure. When there's an increase in intracompartmental pressure, we get a reduction in venous outflow of that compartment. This causes venous pressure and thus venous capillary pressure to increase. If the intracompartmental pressure becomes significant enough and it's higher than the arterial pressure, well, then we get a decrease in arterial inflow, and that's when we start to run into problems. This sort of leads to reduction in oxygen delivery to the tissues, and if a deficit of oxygen becomes significant enough, where we get irreversible necrosis, and that's when we start to get some of the symptoms. So the earliest physical finding is that of or complaint of a tense or wood-like feeling of the involved compartment. The pain is typically severe and out of proportion to the injury, and pain may only be present with passive stretching. This is an early sign. There can also be reduced power of muscles within that compartment. Other symptoms such as paresthesia is also an early sign. Paralysis, pallor and pulselessness is a late sign. So if you do have a patient who displays these symptoms, it's probably getting late into their actual disease progression. Any diagnostic criteria? Well, then none. It's a clinical diagnosis. So if you suspect someone undergoing compartment syndrome, you must act quickly. So we've got a couple of aids here that will help diagnosis. So we've got a manometer to the bottom left here, and what happens here is there's a 20 ml syringe which contains normal saline, and this is gently pumped into the compartment that you're measuring. The pressure is then measured via manometer. It's not the best way, because if you imagine you're injecting some saline into a already tense compartment, so you're making it worse. Nowadays we use a slit catheter, which is the diagram to the top left. This allows more accurate measurements and allows for continuous monitoring. It's also recommended to measure all the surrounding compartments that you're questioning. You can also do an X-ray if we're worried that a fracture may be causing the compartment syndrome, and also we can do a Doppler to check for blood supply. You can also do other things such as bloods if you've got some time, check for rhabdomyolysis, for creatinine kinase, also check renal function tests in myoglobin, and check the urine analysis. But time may be of the issue, so we need to sort of get a diagnosis from the get. So we move on to the leg here, and this is the most common part of the body that you may find a patient having compartment syndrome in. Lower leg is composed of 4 different zones. So there's compartments. There's an anterior compartment, there's a deep posterior compartment, and lateral compartment. Of the compartments, anterior compartment seems to be the one that's affected the most, and this usually undergoes compartment syndrome. This anterior compartment contains the tibialis anterior, the tibial artery, and also the peroneal nerve. The normal pressure within a compartment is around 0 to 8 millimeters per mercury. Anything above 30 millimeters per mercury, and I'd be a bit worried that a patient is undergoing compartment syndrome. If we've got the intracompartmental pressure, we can work out the delta pressure, which is a measure of the perfusion of a compartment. That's calculated by taking away the intracompartmental pressure from the diastolic pressure, and any value that is less or equal to 30 millimeters per mercury is indicative of potentially a need for the management of the compartment syndrome, which is a fasciotomy ultimately. So management on a ward is A, B, C, D, E. Give supplemental oxygen if required. Remove any restrictive cast or dressing, and make sure you keep the extremity at the level of the heart, and this is to prevent hyperperfusion of that extremity. Move on to operative management. So in the lower limb, we want to, in any limb, you want to make a fasciotomy. The anterior compartment of the leg, as I said, is the most common location for a compartment syndrome. Anterior and lateral compartments are exposed by a lateral incision, which is placed halfway between the tibial crest and the line of the fibula. We dissect through fat to avoid any nerve and damage. The anterior compartment then can also be released by opening the intramuscular septum. The posterior and the deep compartments are addressed through a medial incision, which is placed 3 centimeters behind the posterior border of the tibia. We use blunt dissection to avoid any injury to surrounding nerves and veins again. And in the forearm, we've got 3 compartments: a volar compartment, a dorsal compartment, and a mobile wad compartment. We first do a volar fasciotomy, and we would repeat the pressure in all compartments. In some cases, the tissue pressures in the mobile wad and the dorsal compartments are significantly or will significantly decrease after volar release, making a dorsal fasciotomy unnecessary. But if that isn't the case, then we need to do a dorsal fasciotomy too. And in the foot, we have 9 different compartments. We will do a dorsal incision to release the interosseous and adductor compartments, and a medial incision to release the medial, superficial, lateral, and calcaneal compartments, shown in the picture. So in terms of prognosis, when a fasciotomy is done within 6 hours, there is almost 100% recovery of the limb function. After 6 hours, this is where we tend to enter a grey area, and there may be some residual nerve damage. When a fasciotomy is done after around 12 hours, about 2/3 of patients have normal limb function. And outcomes for posterior compartment syndrome of the leg are worse than that for outcomes of the anterior compartment of the leg. This is felt it's difficult to perform inadequate decompression of the posterior compartment. So in summary, we've talked about the causes of compartment syndrome. We talked about some of the presenting symptoms and signs of that pain is an early sign and the pain is out of proportion to the injury sustained, and that paresthesia may also be an early presenting sign. We've talked about diagnostic measures using the slit lamp, and we talked about delta pressures, and we talked about definitive management in several of the compartments, such as the forearm or the limb, that may occur. Thank you.